Good afternoon, everyone. Thank you, Professor Dr. Nagaraj Desai, Dr. Prabhakar Kodegal, and CCA for having me here. And voluminous topic. Each guideline is about 70, 80, 100 pages, sometimes 140 pages, and you have to sift through a lot of information. And what I'm telling today, I don't know if it will really make justice to all the voluminous information and material that we have. But I'll try my level best to condense, concise, and at least give kind of a concentrated version of the whole thing. So today, the topic will be on managing lipids, swiftly changing landscape. Dr. Nagaraj Desai should be congratulated for giving this title and looking at the current guidelines. And now today my focus will be on the recommendations of CSI, LAI, that's the Lipid Association of India, and extended lipid profile. Now, why lipid management is critical? It has a global impact. The cardiovascular disease is the leading cause of mortality in India and worldwide. We all know that. And dyslipidemia is a major modifiable risk factor. Underline the word modifiable. So you can really do something here. And as Dr. S.S. Iyengar said, what we do today for the present will have an impact for the future. So early lipid control reduces ASCVD burden. Again, the emphasis is in the word early. By the time we see manifestations of atherosclerotic cardiovascular disease, a lot of damage is already being done. So sometimes they are irreversible. So it's very important, especially in an Indian context, where the atherosclerotic cardiovascular disease happens a decade earlier, or rather more than a decade earlier compared to the Western population, that we should be picking up these lipid abnormalities very early in their lives and be very aggressive in terms of their management. And this is what we have been doing. Now, the lipid management is critical, especially in India, because we have a very peculiar type of atherogenic dyslipidemia pattern. And that is, we are having LDL cholesterol, which is almost normal or just elevated. Our triglyceride levels are more, and the HDL is low. This is what is called as an Indian or South Asian dyslipidemia pattern, and this compares to the residual risk that is seen in people after statin therapy in the West. So low HDL, high triglyceride, and of course the other moieties like small dense LDL and elevated LPA levels. So the changing global and Indian landscape means slowly you can see that there is a global evolution. They are shifting from the LDL-centric approach to a risk-based stratification, and they are the ACC, AHA, and ESC which are leading the way, but I still don't agree on that. I think it's the Lipid Association of India which is leading the way. And integration of advanced lipid parameters are also happening with advanced lipid marker enhancers and also risk factors. And Indian adaptation, we have been having our CSI 2024 Lipid Association of India, and now we are focusing on extended lipid profiling for better risk assessment. So we have some major updates from 2009. So if you look at the ACC AHA, as has already been spoken about, I don't want to spend too much of time here. We have this enhanced ASCVD risk calculator incorporating just not the risking, but also the coronary calcium scoring and also biomarkers for improved precision. LDL targets, of course, now they have been lowered. And from a very high-risk patient, you can say that we want our LDL to be less than 55. Combination therapies are now being advocated, and just not one single drug, but they want us to start off with combination therapy. So cardiovascular risk categories, low risk, intermediate risk, high risk, and very high risk are the ones that have been propounded. And the very high risk are those who have already an established atherosclerotic cardiovascular disease. They have diabetes with target organ damage or familial hypercholesterolemia. And if you look at the ACC-AHA guidelines, this is what we are up against. Low-risk patients, they want their LDL to be less than 130, and if possible, if you can make it 115, it will be much better in aggressive setting. For an intermediate risk, it will be 100, 85 in an aggressive setting, and of course in a high-risk setting, if it is 70, it's what is recommended, but if you can get it down aggressively to 55, it will be better. Now, when are the times when you want to go ahead with aggressive? When you have other things coming up, like presence of slowly appearing metabolic syndrome, coronary artery calcium scoring slowly building up year on year, things like that. So these are set times when you want to really go a little more intensively and reduce the LDL cholesterol. So target achievement should prioritize lifestyle modification before pharmacotherapy. This is something that has been focused upon in a very great way in the American College of Cardiology, especially in low-risk patients, and with progressive intensification based on individual response and tolerance. So this is the chart, which you can get it on the internet, and you can see here that the LDL in patients who are already on maximum tolerated statin regimen should be focused to less than 55. And you have to, for this purpose, continue not only high intensity statin therapy, but at the same time you have to think of addition of non-statin LDL lowering therapy, and that they say is a class 2A recommendation. So this is something very important which we need to understand. Those who are not at goal, earlier it used to be in the American College of Cardiology only statins, but now you can see these allowances coming up for other drugs for the reduction of LDL-C. And in patients who are not tolerating the statin, there is again a non-statin, addition of a non-statin LDL for lowering of LDL therapy. So how soon should you be repeating the lipid profile? Every 4 to 8 weeks, and till you reach the targets, you should not give up. You should make sure that the LDL-C reduces. So you can see this is a similar graph, but here you can see how even now that there is a class 2A recommendation in patients with ACS who are already on maximum tolerated statin therapy with LDL-C, and they want the LDL-C to be less than 55. You want to get it down to less than 55. And for that, concurrent administration, it's a word important, very, very, very important word. You give it along with ezetimibe, and that's what is very important. And this is definitely a shift in terms of thinking from the American side. So what do you do when you want to go in for lipid reduction? First of all, you will be taking out the risk calculator. You assess the risk of the patient. Do you start there? No. You have to probably do a calcium coronary scoring, coronary artery calcium scoring as well. And then the most important, do you immediately go with drugs? No. Lifestyle changes always come first. You don't immediately go with pharmacotherapy. Remember, this is all primary prevention, not secondary. And of course, diet, exercise, weight management, smoking cessation. And then comes statin initiation. When all of them do not achieve the LDL-C, you go for statin initiation. You will start with moderate to high dose intensity statin therapy based on the risk category. So there's something now coming up, risk category. And of course, you have to monitor and intensify every 4 to 12 weeks, and then you have to think of combination therapy. Now, what is the role of this? All these days we were not talking about this at all. The coronary calcium, the HSCRP, the lipoprotein A. So now you can see the American shift. You can see now that they are getting all these into their decision-making algorithms. The CSE scoring is recommended for intermediate risk patients to refine treatment decisions. So it has to be a shared decision-making. If the calcium score is more than 100, then this patient is pushed to a high-risk category. And there, of course, you go for a high-intensity statin therapy. So you can see how things are evolving. In terms of CRP becomes very important because that will help you have a conversation with your patient, and if the CRP level is more in spite of LDL being at goal, then it is further intensification that is needed or add-on therapy is needed, because if the LDL is at goal, it has reduced, but the CRP is more, that is an important marker for a high-risk patient. Lipoprotein A, we are very sure that it has to be estimated for everybody at least once in their lifetime, because lipoprotein A is a marker of premature atherosclerotic cardiovascular disease. So everybody should have at least once in their lifetime a lipoprotein A estimation done. So the key takeaways now are talks about precision medicine, where guidelines emphasize personalized risk assessment using multiple tools beyond traditional calculators. All these days we thought if you have the calculator on your smartphone, you've done your job. No, it's not easy as that. You'll have to incorporate so many things, including the novel biomarkers that we talked about. Lower targets. Nowadays we are becoming more and more aggressive, and LDL goals are to be achieved at any cost, even with a combination therapy upfront. And now the evidence-based recommendations are grounded because of the robust clinical trial data that we have. So we need to transform the cardiovascular outcomes through guideline-directed medical therapy and precision risk management. So this is now we come from American to Europe. So very high risk, you can see that they advocate LDL of less than 55. And these are the risk categories. For the non-HDL again, you can see that it's 30 milligram more than the usual LDL values. Whatever LDL, you look at non-HDL, it's 30 more. That will be the goal. And this is our own CSI algorithm that you have, which was given in 2024. And in the absence of our own risk score calculator, only risk factors are used for risk assessment. And non-HDL-C is given as a co-primary target because of increased prevalence of atherogenic dyslipidemia. And you can see the cutoffs there. It's less than 70 non-HDL-C with an LDL-C of less than 40 for the extremely high-risk group. And those are the categories, the characteristics of the extremely high-risk group. And for a very high-risk group, they say it should be 55. So this compares well with the American calculator, with the rider that you get it down to 40 when it is extreme high risk. This is our own LI consensus statement. I take you to the last right part because of paucity of time. I'm just given 15 minutes to complete. And you can see here there is extreme risk, category A, category B, and we want the LDL-C to be 30. And if possible, in a very, very timelined manner, we want to get through that. Look at that, timelines, week 0, week 4, week 8. So by end of week 8 to 12, the goal should be achieved. It's not that you are leaving your patients just like that and telling them you come after 6 months or 8 months and all that. No, it's very, very, very structured. And this is what we need to do, and this is according to the Lipid Association of India. We have certain consensus statement telling us how soon we should be doing it. And if you look at the CSI guidelines versus the LAI consensus, you can see that the LAI is more aggressive. CSI probably is more practical, accessible guidelines suitable for general practice with emphasis on lifestyle modification. The Lipid Association of India is more specialist-driven, highly aggressive protocols with detailed risk stratification. CSI focuses on practicality and accessibility, ideal for broad implementation across India. LAI pushes the envelope with precision medicine and ultra-low targets, ideal for tertiary care and high-risk patients. Together, they offer a spectrum of strategies that can be adapted based on resources and patient profile. So extended lipid profiling is very important. As I said, it's very important to do the lipoprotein A and the CRPs and look at co-primary targets. And when to order extended lipid profile, when you have premature cardiovascular disease, younger events and metabolic conditions. And this is just a comparison of all the guidelines that you have. Sorry, this is a busy slide. I think I'll just take you to the last line, right? What we see in very high risk LDL-C goal is 55 for most of the international guidelines. For the CSI and LAI, you can see 55 and less than 30. So we are evolving now. So understanding the differences helps the clinicians choose the most appropriate guideline based on patient profile, resource availability, and care setting. So whether you are in a primary care setting or a lipid specialty clinic, you can make use of these various guidelines. And when you look at it, you get confused. These are all voluminous data, each one 140 pages, 200 pages. And I have just 15 minutes to convey the entire thing to you, so I've tried to make justice. But then, when we see differences in guidelines, it's not about inconsistency. When you look at it, when you sift through the pages, you think, where am I getting into, what's happening? But it's not about inconsistency. It's about the context that they are talking about. Understanding these factors help us apply the right strategy for the right patient in the right setting. Ultimately, it's about delivering care that's both evidence-based and locally relevant. So early screening is critical. Select whatever you want, the guideline. Lipid Association of India seems to be leading now. Extended testing value is important, and acute care protocols should be robustly in place. So call for action is healthcare system level and clinical practice level, both the levels. Thank you very much, and my references are from the American College of Cardiology, European Society of Cardiology, CSI 2024, LIA consensus, and key research papers on ApoB, lipoprotein, lipid targets with PubMed, NCBI, and international journals. Thank you so much.
Thank you, Dr. Venkatesh, for finishing your talk well in time.